Hi, I'm Dr. Jeff Yu, a board-certified ER doctor in both the USA and Canada, and today I'm going to be reviewing the Pitt Season 2, Episode 8. Let's get to it.
Our hospital computers are at risk for a cyber attack, so we are going old school, analog.
This is exactly what it looks like when we go on a code gray, which is when all the IT systems shut down. We have a whiteboard that looks exactly like this with all the different room numbers on them. We also have an accordion file folder that we bust out in the instance of a code gray, and it has a bunch of different papers that you use for ordering x-rays, blood work, also for doing paper charting. It is a nightmare when this happens.
Please, somebody tell me they got a photo of the boards.
Yeah, right here. Okay. Oh, it's a little blurry.
No, I mean, I can remember all of it.
All of what?
Names, doctors, room numbers. I kind of have a photographic memory.
Seriously, the whole board?
I'm pretty skeptical of people who say that they have photographic memory. I've met many people throughout my medical career that say that they have that, but I don't think that this is actually scientifically proven to exist. Most of how memory works is people remember memory through context, and there are different systems to actually memorize things in higher detail than other people, like telling yourself stories and using visualization. But to be able to say that you have the ability to take a snapshot as if you use your phone, I don't think that actually exists in real life. Let me know if you know otherwise.
2 minutes out with abdominal pain and fever.
Okay,
So that red phone is what emergency departments will often refer to as the bat phone. Almost every ER has one. It's how pre-hospital notifications arrive, like paramedics can call ahead if they have a critically ill patient or a trauma that's coming in, so that the team can prepare ahead of time and get all the equipment ready so that as soon as the patient arrives in the ER, we're kind of ready to go.
they will sign them off. They will add a downtime slip on them, make sure they go to the correct department.
I'm sorry, who are the clerks?
You're looking at
Larry and Antoine.
So this is actually very realistic. Typically what we'll do is we'll write down our orders, like if you want to send a patient for a chest x-ray, it has to go on a separate requisition or a separate piece of paper from the blood work. So you send off, chest x-ray with an indication of like rule out infection. They would take that piece of paper, fax it off to the radiology department, and then they would take the separate piece of paper with all the blood work that you want and then fax that down to the blood work department. And then when results come back, they get faxed back to the ER. So it's incredibly disorganized because you're trying to match all the results with a bunch of charts that are scattered around the department. And most oftentimes because emergency departments are quite sprawling, like it's not one centralized nursing station, there's like multiple nursing stations throughout the ER. It's actually hard to find the physical charts to match those results into. So it causes a lot of disorganization and a lot of chaos within the ER.
What's that noise?
You look low landed.
She's never
Aliens
seen
are
a fax
invading.
machine before.
Hey, Dana, Chem 7's not back on trauma 2 yet.
Let me see the chart. You put labs and chest x-ray on the same downtime form. You need 2 slips, one for labs, one for radiology.
Damn, that's so realistic. How do they even know that?
What happened again?
I'll run it down myself.
I am just composing. I'm going to send it from the bay. My mechanic friend Duke never showed up.
Thought he was coming in this morning.
That was the plan. I guess he got busy.
I'm guessing they're setting this up as like his friend has a bad motorcycle accident or something else, and he comes into the trauma bay. I'm calling it right now. You watch it.
What if he's a no-show? Tell me what he needs. I'll pass it on in the night shift.
That won't be necessary.
This is your first shift back going in 9 years and counting. Oh, if you need anything, call me.
Thanks.
I wonder what she was addicted to. It's cool that they included this into the show.
Howard Knox, 52, abdominal pain and fever, 152 over 90, tachy at 120. Couldn't get an IV.
Wonder why.
Hello, sir. My name is Doc.
People who have an obese habitus or increased body mass index, it becomes very, very difficult to get IV access because you're essentially trying to find veins through a lot of subcutaneous tissue or fat. This makes any kind of resuscitation or medical management much, much more complicated because Oftentimes, if you do not have IV access, you aren't able to give life-saving medications when they're needed the most. Oftentimes, if IV access is very difficult, we'll either use an ultrasound to identify where the veins are to insert the IV, or we'll just go straight to using an IO drill to drill into the shin or the upper arm to get some kind of access.
Let us know if this hurts. Sorry.
And on this side?
Yeah.
Sorry.
Guarding with no rigidity for pain 100 of fent IM.
Okay, so there's a lot of information that came at us right there. So he's had some abdominal pain that started in the left side of his abdomen and then generalized to the rest of his abdomen. He's had fever, he feels really well, and he's obviously very sweaty, and when they're pushing on his abdomen, he's quite tender. McKay just said that he has involuntary guarding, which is one sign of peritonitis, which shows like irritation to the actual lining of the abdominal cavity. This often points towards more of a surgical pathology, like possibly like a bowel rupture, ruptured appendicitis, ruptured diverticulitis. These are all things that we would start to think about.
Plan Dr. Whitaker.
Blood cultures, lactate, Zosyn. We're gonna need a CT to figure out what's going on.
So everything that Whitaker just mentioned are investigations and management for intra-abdominal sepsis. So a lactate would indicate if there's signs of end organ damage. Zosyn, which is an antibiotic called piperacillin-tazobactam, is kind of a nuke of an antibiotic that covers both aerobic and anaerobic bacteria. It's the antibiotic of choice when we have someone that's really, really sick and, you know, possibly going into sepsis or septic shock.
Yo, it's not gonna work.
Yep, right neatly penmanship, Ken. My word for the scan. We're gonna have to lay you flat
Force
on
of
your back.
habit.
Can you do that?
I could 10 years ago, but
Intubation with rapid sequence induction.
No, we can't lay him down.
So the tube will go in your nose while you're awake, sir.
well,
Right.
does it hurt?
Yeah, so they're alluding to an intranasal transnasal intubation, which is like quite rare. That's like, you know, that definitely would not be my first choice of intubating someone that is obese or has an increased body mass index. Typically, with someone with this habitus, if you do lie them down flat, then all of the weight of their chest actually does collapse their lungs and makes their oxygen saturations drop a lot faster. So we would often intubate them at this angle, at like a 45-degree angle or higher. We would stand up above the bed and either use the laryngoscope to actually try to find the larynx, or we can do what we call a fiber optic intubation, where we use a long camera that's on a string to guide it down to the trachea, and then once we find the larynx, we guide it down into the trachea and slide a tube off of that camera to secure the airway.
Let's try for a midline. So then with ultrasound guidance.
An ultrasound.
So a midline with ultrasound guidance is where we use an ultrasound to identify the vein in the upper arm over here. And then once you identify the vein, then you would insert a long catheter, which is about this long, that kind of feeds up, and you can feed pretty much any drugs through that line.
Is it possible that you might be over 450?
Possibly.
Check for an appy.
He's a little too large for ultrasound. Unless our CT can only handle 450 pounds.
And so if he's over that, we send him to the zoo?
Yeah.
He's right there.
I heard that there's a large animal CT at the zoo.
Presby CT can handle 650.
Yeah, if Presby's still up and running.
If you have concerns of intra-abdominal pathology, you would need to get some kind of imaging, like the CT scan is the test of choice, but a lot of our CT scanners will not accommodate people that are over a weight of 400 or 450. And in these cases, you would either have to send them to a specialized hospital that has a larger CT scanner that's able to accommodate people with morbid obesity, or you would have to sometimes send them to the local zoo to actually put them in the CT scanner. And that adds a complete different nightmare of logistics, because transferring a patient while they're really sick and possibly deteriorating to have a CT scan at a different area being transported both ways is can be quite dangerous. But I've dealt with this a couple of times through my career, and it's always quite stressful.
Perla, let's call for the Hoyer. So we're gonna place the tube and get you ready for the scan.
I think one thing that I do want to say is, I don't want this to come across as offensive to anyone that is overweight. This is not coming from a judgmental place. This is just one of the challenges that emergency providers do deal with. And, the word obesity is not meant to be offensive in any way.
Have any of you ever done an awake nasal trachea? Okay. Just gonna go over your tongue and numb your vocal cords.
So this is what we call an atomizer. It essentially creates a mist of the anesthetic. And what we would do first is we would spray the tonsillar pillars, which are kind of like the sides of your throat, followed by the posterior oropharynx, which is the back of the throat. And as that becomes numb, we would just go deeper and deeper until we get down to the level of the larynx and spray the actual cords down. And by doing this, we would be able to push a bunch of different equipment into the person's throat without them gagging or like tearing up as we're pushing the equipment down.
Maybe you could ease up with your comments about his weight.
I was just wondering how he got so big and how we could help.
We can help by finding out what's wrong with him and treating him with respect.
Yeah, I 100% agree with that. I think he definitely needs some sensitivity training. I think there is a fine line between gathering information that's relevant to treating a patient and getting them the care that they need versus probing questions in a way that makes them feel embarrassed about their situation.
My pain is a 9.
Gonna get it to order a pizza?
So I used to work a lot in the ICU, and I'm not sure if things have changed in the last like 7-8 years, but when I worked in the ICU, we never had these iPad communication devices. I think this is an awesome improvement in allowing patients to communicate with their healthcare providers while they're on a ventilator. Because a lot of patients are not actually in a medically induced coma. A lot of them are awake and breathing on their own and have the tube still in place to protect their airway.
Thinking it's surgical?
Hoping for a non-perf.
Can you do it with a scope?
Possibly, but he could be treated with antibiotics alone.
If he needs surgery?
With his size, an emergency open laparotomy death rate's close to 50%.
Okay, one step at a time. Let's keep trying his sister every 15 minutes. She'll get it.
So what they're debating between is doing a laparoscopy where they make 4 small incisions into the abdominal wall and introduce cameras to try to find out what's going on, like if there's a perforated appendicitis, versus doing an open laparotomy where you essentially either make an incision from the midline, from the breastbone down to the pelvis, or if you're really suspicious that it's just appendicitis, sometimes they would do a laparotomy by making an incision on the right side of their abdomen over there. But I think with someone with obesity who's already in sepsis or septic shock, the chances of death on a surgical table are going to be quite high, or death that after they go to the ICU.
Okay, the next step is we're going to take this tube and pass it through your nose.
We have to put it in.
So that's the fiber optic scope that we use. Again, I am going to say that this is like quite unrealistic because, for someone that's awake and talking to you just like this, honestly, the most reasonable way to do this, if they've been numbed out in the entire nose and the area of their throat and upper airway, would just to pass that scope through the back of their mouth and then pass the tube, because by doing that you would be able to pass a larger diameter tube, like an 8.0 endotracheal tube, whereas if you go through the nose, typically you're only able to pass a more narrow tube that essentially that's determined by how wide your nostril is. That would be something like a 5 or 6.0 endotracheal tube, and someone that has obesity with a very high body mass index, the amount of volume of air that you need to push through the ventilator is really high, and you just wouldn't be able to do that with a narrow-sized endotracheal tube. So this is not realistic at all.
Here we go.
Okay, so Abbott is pushing the endotracheal tube into his nose. I don't know what is going on. What is going on? This is not realistic. Oh my God. Okay, so typically what we do is we'd put the endotracheal tube at the actual hilt of that fiber optic scope, and then you would introduce the camera through the nose. If you were doing the the nasal intubation, which we wouldn't. But if you were to do a nasal intubation, you would push the scope through the nose with the tube kind of anchored on the base of that scope, guide the camera through the nose down to the level of the larynx and into the trachea. And then once the actual camera is in the trachea, then you would feed the endotracheal tube off of the camera through the nose and just guide it along that camera scope. So for Abbott to be pushing the tube in through the nose without any cameras or anything is just, it's not real. It's not remotely accurate.
Okay, Howard, I'm going to start. If you want me to stop, you just put your hand up, okay? Blue mark tells me I'm in the tube.
Wow. Beautiful.
Cords are sensitive, so we spray lidocaine in the scope.
This will cause him to
1
cough.
cc going in now.
I will just give that a second to work.
Hey, how you doing, Howard?
Once the tube's
In real life, once you push lidocaine down, people will start coughing like crazy. Because even if that area is anesthetized, just fluid going down your trachea would trigger a huge coughing reflex.
then you'll have to breathe through your nose.
Okay, Howard, hold still. I am now going in past your vocal cords until we see the carina.
The carina is the split off between the left and the right mainstem bronchi. We would bring the camera down to that level of the bifurcation, and then that's when we would feed the tube off to secure the airway.
Ogilvy?
There. Right and left mainstem.
And the tube slides in.
Okay, that went really well, Howard. Now we're going to check your weight.
Okay, so typically after you've done an awake intubation, you would then push a bunch of sedation like ketamine or propofol and then completely paralyze them and start breathing for them, especially if someone's in septic shock and they need to get a CT scan and they need a bunch of interventions, possibly even a surgery. We wouldn't keep this patient awake in the ER. Sometimes after all the interventions are done, we would allow them to wake up in the ICU, and that would allow us to do like breathing trials to see if they're ready for extubation. But in the acute phase, this is not very realistic. We would not keep them awake at this point of their management.
No. I will either sit on the sofa or sometimes I'll be in bed, kind of sitting up with the computer on my lap, that kind of thing.
So you're always looking down at the screen?
So I don't even know what the chief complaint is for Harlow, but I am pretty interested to see what this case is about because I feel like they've been kind of teasing this case for probably like 3 or 4 episodes, and I'm guessing that this is going to be a really, really bad, some kind of underlying pathology that Santos has missed or delayed making this diagnosis because of this language barrier.
Hi, well, I think we can help.
So it looks like the patient has some pain in the area of the trapezius muscles. This is something that we often see in people that have muscular torticollis. The most common presentation is people wake up with kind of like a kinked neck and they can't turn their neck and it hurts really badly along the side of their neck and their upper shoulder when they try to turn it. One of the most common reasons that people have this is poor posture, like when they're sitting at a desk, hunched over, looking at a laptop. The other thing is just really bad deconditioning, like they don't exercise, they don't stretch their muscles in any way. It's very common, and typically how we would treat this is by doing a trigger point injection where we inject just a simple anesthetic like bupivacaine or lidocaine and kind of fan it through the muscles to help the muscles to release, and it just provides the person an opportunity to stretch the muscles out to recover.
Here is your antacid. Cheers. And I marked the trigger point that is bringing out your headache, and a shot of local anesthetic in that area could really help.
Yeah, so she is going to go ahead and do the trigger point injection.
Yeah, let's do it.
Great.
Oh, ow, that really hurts.
So one thing I'll note about the trigger point injection that Santos is doing is the trajectory of her needle is all wrong. If you go straight down in that direction, sometimes you can get a complication, what we call it a pneumothorax, because the needle goes too deep through the muscles and actually punctures the apex or the top of the lung and causes the lung to collapse. So typically what we'll do is we'll actually pinch the trapezius muscle like this, and we'll guide the needle in essentially in this plane so that there's no chance that if the needle goes too deep, it will actually puncture the lung.
Dr. Alashimi, can I present? Yes. 32-year-old deaf woman with myofascial headache, ibuprofen caused gastritis, and epigastric pain, and she vasovagaled. But now pain-free after Mylanta and a trigger point injection.
Okay, so Santos is presenting a very, very complicated story for Harley, the hearing impaired woman, saying that she had a headache because of muscle pain. She was taking ibuprofen, which caused abdominal pain, and the abdominal pain is which caused her to faint. And in medicine, there's two different things that we often talk about, which is Occam's razor, which is like one simple explanation or diagnosis can explain entire patient's entire presentation, versus Hickdom's dictum, which is essentially says that patients are quite complicated. They can have as many different disease processes as they damn well please. And Santos is demonstrating Occam's razor, where she's trying to say that, you know, the patient had a fainting episode, a headache, and abdominal pain, and therefore it's all linked to one single diagnosis. But if you follow this path, it means that you could possibly miss other life-threatening diagnoses. And whenever I'm the attending and a resident gives me what feels like an overly simplified explanation for a patient's complex presentation, I'll challenge them to actually sit down and write down all their different differential diagnoses for all the different presentations. So one for headache, one for the abdominal pain, one for fainting, and think about all the different investigations that you would need to do to rule out all the big, bad, scary things.
Excellent. That can take care of the pain for several months.
Yeah, it shouldn't recur if she keeps her screen at eye level. There is a delay in getting an ASL.
I really hope that they don't keep this case just this simple. I feel like that would, I don't know, that would be quite unsatisfying for me if they just keep it, oh, she's healed by this trigger point injection.
Interpreter, and I almost gave up and ordered an unnecessary brain and abdominal CT.
Good thing you didn't.
Dr. Al-Hashimi.
Fingers? I don't see any fingers.
And now?
I can see a little bit of light.
Okay, so when someone comes into the ER with decreased visual acuity or blurred vision, there's like a way to risk stratify how bad their vision loss is. So first you use the Snellen chart, which is, you know, the chart that has all the different letters. You would ask them to see, you know, what letters they can see. If their vision is really, really bad to the point where they can't read the E at the very top, which is 2/200 vision, I believe, then you would go to counting fingers. Like, are you able to count fingers? If they aren't able to count fingers, then you move your hand. Are you able to see movement? If they aren't able to see movement, then you shine a light into their eye and you ask, are you able to see light? If they aren't able to see light at all, then that is complete blindness. But this is kind of like the levels to decreased visual acuity that we look for.
Left eye, no history of hypercoagulable state or vascular disease.
So the reason that they mention hypercoagulable state or vascular disease is because someone that comes in with painless vision loss, one of the things that we would immediately think about is if there's a central retinal artery occlusion or a CRAO, which is essentially like a stroke of the eye where a blood clot completely occludes the blood flow to the eye and causes blindness. The other things that we would typically think about it as well is like a retinal detachment. But there's a few different things that cause sudden severe vision loss without pain.
Retinal exam?
Hard to get a good look.
We need the FOP.
The what?
Yeah, so the retinal exam using the ophthalmoscope is actually very, very difficult without actually dilating their eyes.
See the whole retina without dilating the pupil.
You're looking in the wrong eye.
We start with a good eye for comparison.
That's
Retina
cool.
looks great.
We don't have anything like that in my ER. If we did, that would be pretty sick because that looks sweet.
Now for the bad eye.
Eyes wide open.
How's it look?
Extremely pale, no blood flow.
Digital massage, 10 seconds on, 5 seconds off. Order non-contrast head CT.
There are a few techniques that we can, we often talk about in emergency medicine, like an optic massage, where essentially you're trying to like increase the pressure of the eye and then suddenly release it to hopefully like dislodge a clot. Just think of like having a grape and then like squeezing it quickly to actually like try to dislodge it. I don't know of if there's any evidence that supports that as like a very efficacious measure. Like other things that we could sometimes discuss with ophthalmology and neurology is considered doing catheter-directed thrombolysis, where we actually direct a catheter to actually give a medication that busts the clot open.
Has central retinal artery occlusion. I just spoke to an ophthalmologist at the VA, principal investigator for thrombolytics in cases like this.
So she just spoke with an eye specialist. They're going to consider giving them the thrombolytics or a clot-busting drug to release that clot so that the patient is able to salvage her vision.
Exactly standard of care, kind of risky.
We'll do informed consent. It's our best shot at saving some of her vision.
Your patient, your call. I'm not going to be around long enough for any complications.
So what Dr. Arabi is referring to is sometimes if you give that clot-busting drug, it can cause other complications like intracranial bleeding or a severe brain bleed. And if you give this medication and it converts into a brain bleed, then they've not only lost their vision, but they can become hemiplegic and essentially not able to perform daily activities of living, and they become completely dependent on their partner or their family, which is obviously a very devastating complication to a medication that we administer. So this is something that we always have to weigh the risks and the benefits of doing these therapies and determine, is it really worth taking that risk just for one lost vision when people with really like one eye that works perfectly can live a completely normal and healthy lifestyle?
Percent get better without any treatment.
Only 17%?
Yes, but with the medicine, another 20% can improve. But there can be complications. 2% of patients who receive the medication get worse, and 1% have severe disability or death.
Yeah, administering TPA or TNK, which are the clot-busting drugs for something like a CRAO, is incredibly controversial. I mean, even for an ischemic stroke, sometimes it's actually quite controversial among ER doctors because of the risk of devastating or life-threatening brain bleed.
Honey, this one has to be your call.
I personally would not.
It's our call.
I wouldn't take it.
What would you do without me?
Figure out how to get by. And I'd probably cry for 2 years solid.
2 years, that's all. I want the medication.
Oh shit. She's probably gonna bleed. I think that's where they're taking this in the show.
Hey, we need your full.
Is there a blood test or a brain scan that'll tell us for sure?
Unfortunately not.
When properly medicated, people with bipolar disorder can have successful careers.
So we hope for bipolar.
You could hope for your son's happiness.
With early treatment, 20.
Yeah, so I think if I were to choose between bipolar disorder and schizophrenia, I would certainly hope that it would be bipolar with psychotic features, because I think that would be much more treatable on mood stabilizers and antipsychotics compared to schizophrenia, which often requires long-term depot injections, which are injectable, long-acting antipsychotic medications. And schizophrenia can be an absolutely debilitating psychiatric illness. People lose their families, they lose their careers. A lot of people with schizophrenia end up homeless in shelters. This is something that I see. I mean, like, for sure, there are cases where people can still be quite functional on antipsychotic medications with schizophrenia, but I do think I see a very sub-select group of people with schizophrenia who essentially have decompensated psychiatric illness, which makes their life completely fall apart.
With early treatment, 20% of people with schizophrenia have a complete recovery.
Yeah.
So 80% don't.
This is a new version of Jack.
Yeah, so that's like really, really scary odds, right? Like 80% of people will not be able to live a normal functional lifestyle with schizophrenia. Like I haven't fact checked that, but from my personal lived experience working in the ER, like I think that sounds kind of accurate.
How old was your daughter?
20. Studying architecture at Georgetown. Schizophrenia.
Yeah.
I'm sorry.
Oh, she's good. Living at home, working as a cashier at Giant Eagle. Employee of the month. We still have struggles.
Yeah, that's crazy. I think if you're diagnosed with a chronic psychiatric illness, like you would definitely have to consider changing your defined goalposts for success because I definitely have seen a lot of very high functioning individuals who have lost everything, lost their careers, and you can't really expect them to have a career where very critical decisions are being made. For example, you wouldn't want your ER doctor to have a diagnosis of schizophrenia because if they're deteriorating, it's really hard to identify, where they are in that spectrum of illness. And given that they're making critical decisions that impact other people's lives, that would really make it hard for them to be able to return to practice. So, changing the goalposts and, declaring success if they're able to maintain a job as a cashier, I think is like very reasonable.
Pass. For HIV, we got PEP, post-exposure prophylaxis. 28 days, the sooner you start, the more effective.
So for post-exposure prophylaxis for HIV, typically the guideline is within 72 hours of the exposure, whether it's a blood exposure or a bodily fluid exposure like semen. It's not 28 days. Like I think beyond 72 hours, we wouldn't even offer it.
I'm glad you were here today.
Me too.
Yeah, having a gentle and empathetic nurse to, guide you through a sexual assault examination would be absolutely crucial because it's just like probably one of the most vulnerable situations that you could even be in, even after you were already assaulted. So, yeah, it's really heavy.
It's called preserving the chain of evidence.
Yeah.
Are you fucking kidding me?
Is there a problem?
Jesus
Someone else
Christ.
didn't take the chain.
Police are supposed to pick up the rape kits within 72 hours. This one I did 2 weeks ago.
Damn.
God damn it.
I'd be pissed too.
So, Robbie and Alice Shamir are both with critical patients. Hello. I'm Dr. Langdon. I'll be supervising your care.
Yeah, so oftentimes what we do is we would numb the tip. Like if the laceration is deeper down on the base of the tongue, we would actually numb the tip of the tongue. Then we would throw one suture just at the tip so that we can essentially pull the tongue out and keep pulling it out using that suture so that we can actually gain access to the base of the tongue.
What size suture is that?
Oh, silk. The biggest one we got.
Yeah.
As soon as I cut the needle, you're on traction, Joy.
Oh, that is pretty deep.
This is exactly what happens in real life, and it looks very realistic. I think the special effects people did an excellent job.
You want to bury the knot?
Yeah, I've done these before.
Yeah, so tongue lacerations are one of the most unsatisfying things to repair. And the reason that it's unsatisfying is because oftentimes patients over the next couple of days after you've sutured it closed is they'll feel the knot and the kind of the deformity on their tongue, and they'll constantly be playing around with it in their mouth. And by doing that, they inadvertently undo the knot and it opens right back up and they end up in the ER 2-3 days later and then they have to be stitched up again. Something that we see very frequently in the ER.
Skunk as a skunk.
Should we check a blood alcohol level?
No, it won't change what we do. She can go.
Definitely not a conversation that you should be having in front of a patient, even if they are severely intoxicated.
Joy, do you want to guess her blood alcohol?
Why would I want to do that?
So this is like a big ethical thing, like guessing someone's alcohol level or even taking bets on it. One of the ERs somewhere in British Columbia. I think it was on Vancouver Island. Recently had a news article, and I think there was a lawsuit against some of the doctors or healthcare staff because they were taking bets on the blood alcohol levels of an Indigenous patient. And obviously this was very insensitive and potentially racist and discriminatory. So it was in the news, and it's just a big no-no.
I don't know, because it's fun.
Yeah, Santos's character is like so insensitive, and I think that she introduces a lot of different like ethical and moral issues that comes into play in real emergency medicine.
I pulled the chart from the rack.
You're supposed to sign up on the dry erase board.
You're supposed to have a clipboard for the patient.
I thought the nurses had that.
You know, I know a lot of people get annoyed by Ogilvy, but I actually think that he is like pretty good comic relief for this season. He's a pretty funny character.
Student Dr. Javati, when did this start?
Last night. And have you been on any hikes recently around?
So he's got a diffuse rash on his face, arms, and legs, and it looks like he has bullae, which are like very large, tense blisters. The things that we would typically think about are SJS or TEN. SJS is Stevens-Johnson syndrome. TEN is toxic epidermal necrolysis, which is there are two different diagnoses on the same spectrum of illness, and this can quickly turn life-threatening as well. We would treat this as like a massive burn, essentially, to the body while trying to treat any other underlying autoimmune disorders or reactions to drugs.
Autoimmune severe pruritus?
Yeah, but not as deadly as pemphigus vulgaris. Untreated, the death rate is over 90%.
We need to check for pustules, mucous membrane involvement.
And the Nikolsky sign.
Teamwork.
It's a concerning bullous rash.
We might need a biopsy for pemphigus vulgaris.
It's phytophotodermatitis.
What?
I asked. He was making 3 gallons of margaritas for a party, squeezing fresh slimes out in the sun.
Let's go take a peek.
Huh. Yeah, so phytophotodermatitis is something that we occasionally see during the summertime. Yeah, like usually during picnics, if someone's squeezing a bunch of limes or chopping up celery for like a salad and they get all that plant juice on their hands. Usually it's the fingertips and around their mouth. And then once the sun exposure hits that juice, it kind of gets activated and causes a lot of irritation to the skin, which can cause a rash. You know, like, I feel like his rash is too widespread and the bullae, like the big blisters, are just too pronounced for it to be phytophotodermatitis. Definitely not something that I would jump to as a diagnosis. I think that's something that we would consider a diagnosis of exclusion. You would rule out all the big, bad, scary things like pemphigus vulgaris, SJS, TEN, before, you know, saying, oh, this is just lime juice from the sun.
This is all because of limes? Have you ever squeezed limes outside in the sun before?
I don't think so.
I don't know. Like, in order for him to have this kind of rash, I feel like he'd have to be like showering in the lime juice and then lying down and sunbathing. So for him to have such pronounced bullae to all the way up to his knees and all the way up to his elbows, all over his face, it's not a diagnosis that I would jump to. So I'm wondering if they're like jumping to this diagnosis and in a later episode he'll decompensate and be found to have a different, more serious diagnosis like pemphigus vulgaris or SJS TEN, but that's not something that I would really jump to.
When will you have a bed?
I'm not sure she needs a bed.
She's a febrile infant.
Who is clearly over a month old and looks amazing. Every marker is normal. She has the cold virus.
Infants with rhinovirus can still have a serious bacterial infection.
I can't put a kid with a virus in the nursery, and I can't waste the private room on a healthy baby.
This introduces a lot of the tension that happens within the hospital in real life, where an admitting service acts as a gatekeeper for admission when a patient who we believe in the ER really needs an admission. Obviously, a febrile baby who is less than 3 months is at risk of a serious bacterial infection. And given that this baby Jane Doe doesn't have any parents for like a safe discharge, it's quite obvious, it's black and white that the patient does need to be admitted to hospital. So, you know, for an admitting pediatrician saying that they're not gonna admit baby Jane Doe it's like straight up ridiculous. I would be quite frustrated if I was Dr. Al-Hashimi in this case.
Have your attending give me a call.
Will do.
Oh, that's the resident too. Yeah, if the resident was the one that's blocking the admission, I would 100% speak with the attending and, just have a serious conversation. Sometimes we have to involve management and escalate the situation if they still continue to gatekeep the bed for a case like this.
Parents of Roxy Hamlin.
She broke her leg? Yeah, there's a fracture down by the ankle. She's in a boot now, so there's not quite so much pain, but I'll take you. She's just a 9.
I feel like this is going to be quite heavy. I've seen this situation many times in the past where someone has end-stage cancer, the parents of that patient are at the bedside, and it's always quite emotional because I feel like no parent should ever have to bury their child. It's just one of the saddest things.
Can she have ice cream?
She can have anything she wants.
Come on, let's go.
Wow.
Ah! I knew this one was going to be emotional. Ah.
My hospice patient Roxy's still in a ton of pain.
Where are we with the morphine?
10 milligrams an hour.
Okay, you can bolus another 2 and go up to 12. I will let Princess know.
12 an hour is a lot.
Yeah, on top of the MS cotton.
So 12 milligrams of morphine per hour is actually not that much, especially for someone that has been using opioid pain medications for a long period of time. Like to give you an example, a lot of patients with chronic pain or opioid addiction will sometimes need hydromorphone 8 milligrams, which is like a massive dose of hydromorphone. It's like probably 8 times the dose that any non-opioid user would be able to receive, and sometimes they even need higher doses than that. So it really depends on the person's experience with that pain medication, their tolerance to it. Typically we would do this in a supervised setting as well. Like she is in the emergency department, so we would be able to see if she has any toxic effects to, like being overdosed on an opioid pain medication and be able to rapidly reverse that with naloxone if it was absolutely necessary.
She could stop breathing.
Are you familiar with the doctrine of double effect?
Not really.
It is an ethical principle in palliative care. We treat pain. And if in doing so there's a negative side effect, we accept it.
Even if the negative side effect is death.
In some cases, that could be the best outcome.
I've never heard this term double effect. I mean, it makes sense. It's from a pragmatic standpoint. One of our core duties as doctors is to alleviate suffering. And to alleviate suffering, especially in someone with a terminal illness, we give pain medications. Opioid pain medications are some of the most effective medications that we have available to us, but the biggest downside is that it can suppress their breathing. I guess like there is a blurred line between giving them enough opioid analgesia to the point where they stop breathing. That kind of borders into the realm of medical assistance in dying. So I'm not sure if that's where the show is leading us, but yeah, it definitely is a bit of an ethical discussion.
Ask the thanks. You can't leave the PDS. Nothing's getting done here.
All right, so that's it for season 2, episode 8. I thought it was an interesting episode overall with some emotional moments from the sexual abuse case and also the terminal cancer patient. Maybe it's just because I'm a doctor and because I see this stuff in real life, but I thought the nasotracheal intubation and the management of the obese patient was quite unrealistic, and that was, I don't know, it's hard for me to get past that, especially for a show that, takes pride in being like the most medically accurate TV show in history. I just don't think that was very accurate. If you thought this reaction video was interesting, educational, or entertaining, please give it a like and subscribe to the channel. I post a lot of educational short clips on Instagram and TikTok, so you can follow me at Dr. Jeff Yu, and I'll see you in the next one.